Hey, thank you very much. It's great to be part of such a great webinar. So here are my disclosures. So we're all aware that the tragedy of the COVID pandemic has been a huge digital accelerator for healthcare delivery. But it's a really interesting question to ask. Why has it taken a pandemic to move work forwards in this space when we already had much of the digital infrastructure and enablers to support us working virtually? And I think if we understand and learn from these barriers, then this can inform us on how to accelerate change for future. It can promote adoption and future-proof our systems to give us more agility for any challenges ahead. Now, we did see remote monitoring used very successfully in the acute COVID setting, and O'Carroll et al. In the European Respiratory Journal showed very nicely that acute COVID care using the patientMpower platform led to shorter lengths of stay and facilitated discharge for patients with mild to moderate disease in a very safe manner. So acute care was clearly up there as a public health and national priority, but we did see that maintaining chronic service delivery was problematic and less of a priority. And so what we know is that telehealth up until the COVID era was very slow and very fragmented, and even Australia, which is ahead in this area, showed that telehealth represented less than 1% of all specialist consultations. So why is this? Well, it's interesting to note that it is often clinicians who are the barrier and who are often unwilling to adopt telehealth and need to be convinced that it's clinically effective, at least non-inferior, it is safe, and that it can be normalized into clinical practice. So if we look at the potential barriers to embedding virtual care into healthcare systems, we've already touched on some for the clinician. If we think about the patients, well, in fact, patients are actually ahead as consumers, often wearing these wearable devices or using self-care apps to guide them. So there will be issues around clearly patients and their digital health literacy that need to be addressed. And we do know that in ILD patients, some estimate that a significant percentage, possibly up to 30%, are not computer literate or have a smartphone. And so it's not a solution that will suit all. It's very important to see where remote monitoring fits into existing digital ecosystems, which is the middle structure of this pyramid. And this is important to avoid silo working and to avoid platform fatigue by clinicians. If we think at the top of the organizational barriers, from the organization's perspective, they want to understand the cost implications, and they want to be able to demonstrate that any potential cost advantages are present to mitigate the obvious expense of remote monitoring. So if we look at the rationale for virtual care has really come into clear focus during this pandemic. But there was rationale for its use before this. And what we know is that there are clear practical and clinical benefits for interstitial lung disease patients. And I will clarify these very shortly. But prior to that, I just want to touch on one key benefit, which may not be immediately obvious, which is that remote monitoring will allow new types of data streams to be collected in different contexts and different clinical environments. And this means that there'll be huge learnings that can be derived from these types of data streams, whether it's by artificial intelligence or other means. And this can inform us about disease progression and disease behavior in a very different way. And secondly, if there's no baseline virtual care program prior to a disruptive event like COVID, then it's very difficult to upscale this to ramp it up for chronic disease in a hurry, as we've seen to our cost. So what would be ideal is a hybrid system of virtual care, remote monitoring, coupled with the traditional care that we're all used to, and seeing this being flexed in an agile way according to the needs of the individual, the service, the organization, and in response to public health and national needs. Any redesign of any clinical pathway must ensure that we have at the core of it clinical effectiveness, patient safety, and patient experience prior to any transformational change. And really this does mean that patients should be contributing to and co-designing these pathways very clearly, as they have done with the patientMpower app. and this will drive up use and adoption. So patients can get more activated and more engaged with their health by these means. And in this systematic review by Walker from New Zealand on patients' beliefs, attitudes, expectations, and experience of remote monitoring, and this was across a number of different chronic diseases and across 8 countries, they found that remote monitoring enabled and increased understanding of patients' condition by allowing them to track and respond to change. It supported their self-care, it supported their shared decision-making, and it gave them reassurance and peace of mind and security that they were being monitored at home. It provided timely and accessible care, but there were also themes around having to learn something new, about lack of trust in technology and losing the face-to-face contact that is clearly important to acknowledge. So if we think about this as a contributor, if we think about remote monitoring and virtual care as a contributor to a more personalised care approach, then this sits very well with our national body in the UK NHS England, which advocates supporting self-care management by building up knowledge, skills and confidence for patients in their health and disease. And this can be measured using activation instruments, and one such instrument is demonstrated here, which is the PAM score, or the patient activation measure, developed by Insignia. And level 1 is disengaged, and level 4 to the right is highly activated. And understanding how remote monitoring changes over time using this activation score will be very useful. So thinking now specifically about interstitial lung disease, we know that this has been a particularly challenging group to look after in pandemic times. Patients have been shielding, they're vulnerable, many are immunosuppressed and have potentially suboptimal vaccine responses because of that. We have data that shows that these patients have had increased susceptibility and severity from COVID, and in a multi-centre UK audit of ILD patients led by Professor Gisley Jenkins, their data showed that there's increased risk of death from COVID, particularly for ILD patients with poor lung function and obesity. So there is evidence that forced vital capacity measurements are very useful by home monitoring. We know that these are integral to ILD care and are prognostically relevant. And in the UK, we have FVC measurements as a determinant of antifibrotic treatment start. So the lack of lung function testing that occurred in the COVID environment, coupled with patients' preferences not to travel, really has been problematic, and that's driven a lot of the remote monitoring and home spirometry interest in this area. So the remote monitoring obviously can be by Bluetooth linked spirometers, and we can also use oximeters, and these can be standalone or part of a supported digital environment such as the patientMpower app. And we know from earlier studies back in 2016, and the top reference is a UK study by Anne-Marie Russell, who studied a subgroup of patients enrolled in the profile study, that home spirometry is feasible, and in this study showed very excellent correlation with hospital readings. Furthermore, the rate of decline in FVC was highly predictive of outcome and mortality. So in clinical practice, therefore, we have a clear rationale for using remote monitoring in interstitial lung disease, with the benefits summarised on this slide below. However, in terms of evidence-based, in the clinical environment, there is actually only very limited evidence from randomized controlled trials. In fact, there's one randomized controlled trial by Moore et al. From the Netherlands, who conducted a study in 90 patients over 24 weeks, and they chose to use a primary endpoint of between group difference in quality of life measured by the K-Build score. And although this was not met as a primary endpoint, the home monitoring was greatly appreciated by the patients and tended to improve their psychological well-being. There's been a Canadian study by Kerry Johansson in 2017 showing home spirometry is reliable and feasible with good adherence, and also data from the INMARK study published in the ERJ this year showing that, again, home spirometry was feasible with high adherence. So if we look at non-IPF ILD, so a larger group of heterogeneous diseases, there is an abstract from the Injustice study showing good adherence with home spirometry. Some of the home spirometry values were underestimates compared to hospital readings. There's another study by Edwards in 2020 using the patientMpower app, and very much a patient-led research group from Ireland and USA drove this project in a variety of conditions of fibrosis. And this showed, again, long-term use of the patientMpower app was feasible and effective. In sarcoidosis, there's much more limited data. There's only one small study, and so this needs a much further attention. So how do we actually create a virtual system of care for interstitial lung disease patients that's well embedded in a clinical pathway, is sustainable at the level of the individual patient, the clinical service, and the host organization? And in my view, the key is understanding the digital ecosystem of the host organization. So in my institution at Imperial, this involves a mature electronic patient record, as well as a patient-facing portal, and having integration of any remote monitoring systems or platforms into the big hospital systems will, in my view, help with clinician engagement and avoid platform fatigue. What that means is that all staff can access key data via a single sign-on, as well as having cohorts of key involved clinicians having access to bespoke clinical dashboards. So we already had, from 2017 onwards, virtual working and telemedicine, including video conferencing via our patient portal, which is called the Care Information Exchange, powered by Patients Knows Best. This is the largest portal serving the population in the UK, and this allows patients to manage all their healthcare and support self-care and personalised care. And that's really using a dashboard with tabs demonstrated here to enable the patient to tailor their care. And one of those tabs, as you can see, has measurements described, and these measurements can include lung physiology measurements, as you can see there, forced vital capacity. And what you can see with this test patient is that within our patient portal, we have created the ability to integrate with the patientMpower app so that any forced vital capacity measurements, which are shown here over time graphically, can be clear in their derivation as to where they have originated from, and it's patientMpower here as opposed to the hospital system. So what this is demonstrating is successful integration of the platform with our hospital portal. This obviously is going to be complementary and additional to the dashboard for clinicians that the patientMpower app will provide. And so in a virtual model of care, as I've described, what we will see is that we have a system where you can have video consults with patient-generated data from remote monitoring at any time. And what this does is that this can disrupt the normal paradigm of episodic 4-monthly reviews by clinicians by allowing clinicians to react in real time to the data by a system of alerts. But this also allows data to be viewed at traditional times of clinic consults, also using video consultation. So at Imperial, what we're trying to do is evolve a type of digital logistics hub where teams can be allocated to manage these data streams. And the hope is that the clinical benefits from earlier intervention, earlier treatment, admissions avoidance, and so on will become clear using this whole virtual model of care for interstitial lung disease. I do want to briefly touch on the fact that we need to understand who we are leaving out. And in many of the studies that I've discussed, there has either been no breakdown of ethnicity or the recruitment was mainly Caucasian. And from work that we've done on our patient portal population, we know that certain ethnicities and certain patients from high levels of deprivation are in fact less represented in the portal and other digital platforms. So it's important to understand how to work towards making these systems much more inclusive. And as I alluded to earlier, we do also need to address the concept of digital health literacy. So we're about to start on an ethics-approved feasibility study, a multi-centre UK study funded by Innovate UK, which is a prospective single-arm study, and we'll be looking primarily at adherence, but we will be using some other secondary endpoints which will add to the body of literature, and in particular we'll be looking at patient activation scores, but importantly also healthcare resource costs, so that we can start to understand strategically where these solutions fit into organisation and national policy. We will also be looking at the numbers and proportion of alerts, and we shall also be looking at the proportion of FVC changes identified. So with this data, we hope that we'll be able to evidence-base this virtual model of care in interstitial lung disease and be able to embed this into our centre and hopefully into national clinical pathways. And hopefully this will give us the agility to upscale remote monitoring as needed as part of the future preparedness that we've seen to have been essential during this last pandemic. So I'll stop there and hand over to the next presenter.